So now we will discuss about anticholinergic drugs. In the previous lecture, we discussed about cholinergic drugs and cholinergic functions. And now we will discuss anticholinergic. So first, let's see what anticholinergic drugs are. So they are basically cholinergic blockers. They block muscarinic and as well as nicotinic receptors. Muscarinic in the sense that they block M1, M2, M3, M4, and M5, and nicotinic, they block NN and NM receptors. So the drugs that block NN receptors are known as ganglion blockers because, as you know, NN receptors are present in the ganglia, while the drugs that block NM receptors are known as neuromuscular blockers because they are present in neuromuscular junctions. Now, what are the drugs that block muscarinic receptors? Let's just discuss first. So, atropine and scopolamine, they are two drugs that block muscarinic receptors, and they are obtained from natural sources, like they are natural muscarinic blockers. So, atropine is obtained from a natural source known as Atropa belladonna. It's a plant, while the scopolamine is obtained from Hyoscyamus niger. And as you know, I already discussed that they both are non-selective antagonists. Non-selective meaning that they act on M1, M2, M3, M4, and M5. They are not selective for any specific receptor, but they block all of them. So now we will move on towards the actions of these anticholinergic drugs. So basically, first of all, we will discuss about the actions of anti-muscarinic drugs on the CNS, central nervous system. So atropine, basically, which is obtained from Atropa belladonna, is a CNS stimulant because, as you know, atropine is anti-parasympathetic. So parasympathetic is, rest and digest condition. So the CNS goes to the rest, while killing it, like blocking the action of the acetylcholine, we use atropine. So atropine is CNS stimulant, while the scopolamine is CNS depressant, or it makes the CNS go into the depression. So, I repeat, atropine is basically CNS stimulant, scopolamine is CNS depressant. So this scopolamine has some further uses due to its CNS depressant action. This scopolamine, which is also known as hyoscine, is used to induce twilight sleep. Now, what is twilight sleep? It is basically an amnesic state, and the patient feels no pain. Basically, this was a practice used back in 19th and early 20th century. It involved administration of a combination of drugs like morphine and scopolamine to laboring women to reduce pain and consciousness during delivery. Now, this approach aimed to provide pain relief while minimizing the woman's memory of the childbirth experience. So, scopolamine, along with the morphine, is used to induce twilight sleep. Now, the next is, it is used as lie detector and truth serum. Why? Because, as you know, it is amnesic, and the person, goes to a subconscious state and, spit out all of the truth. So it is used as lie detector and truth serum. And it is also used to prevent motion sickness. Now, basically, scopolamine is available in the transdermal patch dosage form, and you take it and you put it behind the pinna of your ear, and what it does is it prevents the motion sickness. So this is a major use of the scopolamine. I repeat, it induces twilight sleep, it is used as lie detector and truth serum, and it prevents motion sickness. Now we will discuss central anticholinergics. So in central anticholinergics, we have benzhexol, which is also known as trihexyphenidyl, and benztropine and piperidine. Now they are used in the treatment of Parkinsonism. Now, in the Parkinsonism, you know that the patient acetylcholine levels are too high in the brain. And what it does is, in order to reduce that acetylcholine, we have to block it. And so these drugs are anticholinergics, and they are used in the patients with drug-induced Parkinsonism. I repeat, it is used in the drug-induced Parkinsonism. Now we will discuss what these anticholinergic drugs like we have drugs like atropine, homatropine, and cyclopentolate, and tropicamide. Now we will discuss what these drugs do on the eye. Now these are used in the eye for various purposes, and we will discuss each of them in detail. Now first we have mydriasis. Now mydriasis, as you know, is the dilation of the pupil. Now it is used in the fundus examination. Now in the fundus examination is basically used to visualize the maximum retina part. Now to visualize maximum retina part, we have to dilate the pupil. Now in the for dilating the pupil, we use atropine and anticholinergic drugs. This is the first use. These drugs are used for the mydriasis, which is used for the fundus examination. And what is fundus examination? It is used to visualize the maximum part of the retina. Now the next is, these drugs are used to induce cycloplegia. Now what is the cycloplegia? It is basically the blockage of the ciliary muscle and to block the accommodation reflex for the correct assessment of refractive errors. Now if a patient goes to the optician and he has a refractive error in his eye, now the optician will use these drugs to induce cycloplegia for the correct assessment of refractive errors. Like these drugs are used for the correct assessment of retina visualization, these drugs are also used for the correct assessment of refractive errors in the patients. Next is, they are used in a condition called iridocyclitis. Now what is iridocyclitis? Iridocyclitis is basically a pain in the patient's eye due to spasm of ciliary muscle. Now basically ciliary muscle is hyperactive and it is causing spasm. Now what we do is we block the ciliary muscle due to these anticholinergic drugs, and we cause cycloplegia basically. Now cycloplegia is the blockage of ciliary muscle, the relaxation of the ciliary muscle. So iridocyclitis pain is relieved and the patient goes to the comfort zone. Now, I repeat, these drugs are used to cause mydriasis. Mydriasis is used for the fundus examination of the retina, and these are also used to induce cycloplegia for the correct assessment of refractive errors. And in the patients with iridocyclitis, a condition in which the patient has eye pain due to spasm of the ciliary muscle, we also use these drugs to induce cycloplegia and relieve that pain through cycloplegic action. Next we have is, now the atropine in all of these drugs has very long duration of action, typically ranging from 3 to 5 days. And for this reason, it is avoided in adults, because the patient, if he takes atropine, he will have the visual problems because of the dilation of the pupil. Now, in other organs, it has short duration. Now, atropine, I repeat, it has long duration of action, 3 to 5 days in the eye, but in the other organs, it has short duration. Now, due to its long duration, it is avoided in adults. Now, hyoscine, it has the long duration of action like atropine, but it has more potent mydriatic action, like it dilates the pupil to the more potency. Now, for this reason, hyoscine is also avoided in the adults because it has more potent mydriatic action. And now one thing to specify here, that tropicamide is the shortest acting agent in all of these drugs, while the, as I have already discussed, atropine is the very long duration of action, 3 to 5 days, while the tropicamide is very short acting drug. And all of the drugs are contraindicated in the patients having glaucoma, because as you know, in the glaucoma, the intraocular pressure of the eye is increased. If we give these drugs, they produce mydriatic action and intraocular pressure is increased. So all of the drugs, anticholinergic drugs, are contraindicated in the patients having glaucoma. You understand? Next, we will discuss its actions, like anticholinergic actions on the heart. Now, atropine, when acts on the heart, it causes bradycardia initially, but as you keep increasing the dose, it causes tachycardia. How? Now, M2 receptors are present in the heart, and when atropine acts on them, when it inhibits the presynaptic M2 nerve terminal, it causes bradycardia initially. But when it acts on when you keep increasing the dose, it acts on the postsynaptic nerve terminal and it causes the tachycardia. Now, I repeat, Atropine basically acts on the M2 receptor and inhibits it. And now, if you give atropine, initially it causes bradycardia due to the presynaptic M2 nerve terminal inhibition, while if you keep increasing the dose, it causes tachycardia due to postsynaptic M2 nerve terminal inhibition. Now, for this reason, atropine is used in arrhythmias, particularly due to AV block, because it stabilizes the heart rate. And it is also used in bradycardia, digitalis-induced bradycardia. Now, in the digitalis-induced bradycardia, we use atropine and it affects the heart rate and stabilizes it. Now, one thing to note here, atropine has negligible action on the BP, blood pressure, and heart contractility. It only acts on the heart rate, and it doesn't act on the BP, and it doesn't show any action on the heart contractility. I repeat all of that. Action on the heart. Atropine basically acts on the presynaptic M2 nerve terminal and it causes bradycardia initially, and then it acts on the postsynaptic M2 nerve terminal and causes tachycardia. Now, for this reason, for these both actions, atropine is used to minimize the arrhythmias due to the AV block, and it is also used in the digitalis-induced bradycardia. Next, we move on towards its action on the lungs. Now, in the lungs, as you know, M3 receptors are present, and the cholinergic action of the M3 receptor causes bronchoconstriction. Like if acetylcholine acts on the M3 receptor, it causes bronchoconstriction. While if you block the M3 receptor, bronchoconstriction reverses, which is the anticholinergic action, like bronchodilation happens. Now, there are two drugs which are important in this category. One is ipratropium bromide and the other is thiotropium bromide. Now, they both are used to treat COPD, which is chronic obstructive pulmonary disease, and they are also used in bronchial asthma. Now, they both are, as you know, anti-muscarinic drugs. Now, ipratropium bromide is non-selective muscarinic drug. Like it acts on all of the M receptors, M1, M2, M3, M4, and M5. While the thiotropium bromide, it selectively acts on M1 and M3, and it doesn't act on other muscarinic receptors. Another drug we will discuss here is glycopyrrolate. Now, it is also a non-selective muscarinic drug, and it is a pre-anesthetic medication. Like it is used for the before anesthesia to decrease respiratory secretions and to prevent reflex bronchospasm. Now, glycopyrrolate is a pre-anesthetic medication that is used before surgery, like to decrease the respiratory secretions, and it is also used to reverse bronchospasm, to treat bronchospasm. I repeat all of that. And now, M3 receptors are present in the lungs. You inhibit them, it causes bronchodilation. Now, ipratropium bromide and thiotropium bromide and glycopyrrolate are drugs used for it. They ipratropium bromide and thiotropium, they have their selective, muscarinic action. It is non-selective, while it is selective M1 and M3. Now, they both are used in COPD, chronic obstructive pulmonary disease, and bronchial asthma. Now, glycopyrrolate is a non-selective muscarinic drug which is used before surgery to decrease respiratory secretions, and it is also used to prevent reflex bronchospasm. Next, we move on towards the anticholinergic drug actions on the GIT, like gastrointestinal tract. Now, in the gastrointestinal tract, as you know, the M1 receptors are present, and the parasympathetic response to the M1 receptor is increased motility, tone, and secretion. Because the parasympathetic state is basically known as rest and digest condition. So digestion means increased motility, increased tone, and increased secretions. While if we block the M1 receptors, like if we give the anticholinergic drugs, they decrease motility, tone, and secretions. You understand? Now, first we have pyranzapine and telanzapine, and they are selective M1 blocker. Like they act on the M1 receptor and block them, and in result decrease motility, tone, and secretion. Now, for this reason, they are used in the peptic ulcer disease, because in the peptic ulcer disease, HCl secretion is increased. Now, we block the M1 receptor to decrease the HCl secretion, and we give pyranzapine and telanzapine for this purpose. Next, these drugs like hyoscine, dicyclomine, propenthylene, oxyphenonium, and clidinium are antispasmodic agents. Like they relieve the spasms because they are anticholinergic. Spasm means increased motility and tone. If you block the M1 receptor, spasmodic action is produced. So these drugs are antispasmodic agents, and because they are antispasmodic agents, they are used in the intestinal colic, in which spasmodic condition is exaggerated. Now, I repeat, paransipine, telanzipine, they are selective M1 blockers, and they are used in peptic ulcer disease. Now, these agents, hyoscine, dicyclomine, propenthyline, oxyphenonium, and clidinium, are antispasmodic agents, and they are used in the intestinal colic. And we have another drugs like darifenacin and solifenacin. Now they are selective M3 blockers. Now, M3 receptor, as you know, remember, they are present in the bladder, and they are also present in the GIT. Now, for this reason, they relieve the irritable bowel syndrome. Now, darifenacin and solifenacin, because they are selective M3 blockers, they are used to relieve irritable bowel syndrome. Next, we have the action of the anticholinergic drugs on genitourinary tract. Now, these anticholinergics, what they do is they decrease the motility of the urinary tract, and thereby they cause urinary retention. How? Because the parasympathetic state, as you know, is rest and digest condition. So the person is resting, so micturition increases. While if you give anticholinergics, the opposite of that, urinary retention happens. Now, because of the urinary retention, they are contraindicated in the patients with benign prostatic hyperplasia. Because in this specific condition, benign prostatic hyperplasia, the prostate is pressing the urethra, and already the urinary retention is happening. So the patient is suffering. Urination is not happening. So we abstain. We don't give anticholinergics in that state. Now, some drugs like dicyclomine, flavoxate, and oxybutynin, they are used in the urinary incontinence. Now, what is urinary incontinence? It is basically the involuntary loss of urine, the leakage of the urination, like the patient has inability to control urination due to detrusal muscle instability. Now, for this reason, these drugs like dicyclomine, flavoxate, and oxybutynin is used because they cause urinary retention in the patients with urinary incontinence. Now, they're also used in the patients with renal colic. Now, what is renal colic? It is basically the obstruction of urethra due to a stone or anything else like that. So, these drugs, dicyclomine, flavoxate, and oxybutynin, also are used in the treatment of renal colic. Now, in these drugs, oxybutynin is the most short-acting drug, and it also causes severe dry mouth. As you know, dry mouth is due to the decreased secretion of the mouth, like saliva. Saliva is not producing, so oxybutynin causes severe dry mouth. Next we have is trospium. Now, the trospium has quaternary amine structure, and the property of this quaternary amine structure is that the trospium doesn't pass the CNS, so it has minimum CNS, central nervous system penetration. And in the patients with the less cognitive impairment, like the patients with like elderly patients who have cognition problems, we give trospium because it has minimum central nervous system penetration. And the other effect is the trospium is not metabolized in liver. All other anticholinergics are metabolized in liver, while the trospium is not metabolized in liver. For this reason, trospium is very safe and can be given with the cytochrome P inhibitors. I repeat, trospium has quaternary amine structure, and for this reason, it has minimum CNS central nervous system penetration. And due to this advantage, trospium is used in elderly patients who have less cognitive impairment, less cognitive function. So it causes less cognitive impairment, I would say. So trospium, it also has other properties, like it is not metabolized in the liver, and all other anticholinergics are metabolized in the liver, while trospium is not metabolized in the liver. For this reason, they can be safely given with the CYP inhibitors. Next is some drugs like darifenacin, solifenacin, tolterodine, and fasoterdine. Now, they are used in urinary incontinence. Like I already discussed, the patients having urinary incontinence have no control, or involuntary loss of urine happens in them, and you give these drugs, they are selective M3 inhibitors, so they can treat urinary incontinence due to their urinary retention action. Now, they are also safe in cognitive impairment patients. Why they are safe in cognitive impairment patients? Because they are slight M1 inhibitor. So they have two actions: selective M3 inhibitor action, which causes which is useful in urinary incontinence patients, and selective M1 inhibitor action, which is useful in cognitive impairment patients. Next, there is an other class of the drugs which is used in overreactive bladder, basically, which is mirabegron, and it is beta 3 receptor stimulator. So this is a latest class of drug which is being used in overreactive bladder, mirabegron, and it is beta 3 receptor stimulator. So this was all. Next, we have other uses of the anticholinergic drugs. Now, the botulinum toxin, which is an anticholinergic agent, it has two types, type A and type B. The type A is used in strabismus, which is a visual disorder commonly known as crossed eyes or squint, and it is also used in blepharospasm. Blepharospasm is a condition characterized by involuntary and repetitive eyelid spasm, and it causes blinking, severe blinking. And it is also used in cervical dystonia. Cervical dystonia is also known as spasmodic torticollis, and it is a neurological disorder that affects the neck muscles, causing involuntary contractions and abnormal head postures. And the botulinum toxin type A is also used in glabular lines. Now, glabular lines, often referred to as frown lines, are the vertical lines that appear between the eyebrows on the forehead. And the type B is used in cervical dystonia, which is also known as spasmodic torticollis, already discussed, and it is neurological movement disorder that causes involuntary muscle contractions in the neck. So basically, for all these antispasmodic activity, we use botulinum toxin. Next, some agents like thiotic acid is used in the late mushroom poisoning of some species of Amanita phalloides. Now, this is a mushroom, Amanita phalloides, and if someone ingests it, we give them thiotic acid to reduce the late mushroom poisoning. Now, thiotic acid is also used for organophosphate poisoning, and it is also used in organocarbamate poisoning. And atropine is also used, but spot the difference. Atropine is used in the treatment of early mushroom poisoning, while the thiotic acid is used in late mushroom poisoning of Amanita phalloides. Atropine is used in treatment of early mushroom poisoning of some inocybe species. But atropine is contraindicated in Amanita muscaria. Now, this is a mushroom, and it causes severe muscarinic actions like hallucinations and severe salivation, sweating, and kind of symptoms. So, if we give atropine, which is anticholinergic in Amanita muscaria ingested patient, so the symptoms worsen and the patient may get in coma and severe hallucinations. So atropine is contraindicated in Amanita muscaria patients. And I repeat, botulinum, other uses of the anticholinergic drugs include botulinum toxin type A and type B. Type A includes these kind of diseases, and type B is used in cervical dystonia. Thiotic acid is used in late mushroom poisoning of the Amanita phalloides, and it is also used in organophosphate poisoning and organocarbamate poisoning. Atropine is used in the treatment of early mushroom poisoning of some inocybe species, and atropine is contraindicated in Amanita muscaria due to severe muscarinic actions produced by this mushroom. So this was all about today. Keep following sqadia.com for more such videos.
Ever felt overwhelmed by the traditional way of learning medicine? Enter the future of education with digital learning. Whether you're refining your knowledge of biochemistry or immersing in cell biology, it's all there. Understanding complex medical subjects has never been easier or more efficient with engaging, interactive content. Welcome to the new age of medical education. Learn anywhere, anytime. At your pace. Powering your medical journey. sqadia.com